The speaker is Dr. Mickey Rourke, a consultant in cross-cultural medicine. You're listening to a talk at a continuing education seminar for healthcare professionals. You have 90 seconds to review the questions. Good afternoon, and thanks for joining today's session. I'm Dr. Mickey Rourke, and I specialize in cross-cultural medicine and healthcare equity. What I want to explore with you today is the real-world impact of cultural competence on patient outcomes, staff dynamics, and institutional trust. Now, when we use the term cultural competence, some practitioners imagine it's about memorizing customs or dietary restrictions. But that's really just surface-level knowledge. True cultural competence is about something far more complex. It's about cognitive flexibility, our ability to recognize and adapt to different cultural frameworks that patients bring into the clinical setting. Let me give you an example. A few years back, I consulted on a case involving a Middle Eastern patient with advanced cancer. The care team insisted on full transparency about his prognosis, following Western norms of informed consent. But the patient's family was deeply distressed. In their culture, discussing death openly with the patient is seen as cruel. They believe the information should be managed by the family to preserve hope. The medical team, though acting ethically within their own paradigm, caused significant emotional harm simply by failing to pause and consider a cultural sensitive approach. That leads me to my next point. Cultural competence is not about compromising clinical integrity. It's about enhancing it. If we don't take time to understand our patients' cultural frameworks, we're not practicing person-centered care. We're just delivering medicine in a vacuum, and the consequences can be serious. Miscommunication, poor adherence to treatment, and, in extreme cases, medical error. I also want to talk briefly about nonverbal communication, which is often overlooked, but critical part of cultural interaction. For instance, in some East Asian cultures, prolonged eye contact can be seen as disrespectful. In contrast, in Western settings, lack of eye contact is sometimes misread as dishonesty or avoidance. So when a clinician expects direct eye contact from all patients, they may incorrectly interpret culturally appropriate behavior as suspicious or uncooperative. Let's also not forget the issue of implicit bias. All of us, myself included, carry subconscious beliefs formed by our cultural environment. The key is not to eliminate bias completely. That's virtually impossible. But to recognize it and actively mitigate its impact on patient care. When a healthcare worker, for instance, assumes a patient from a particular background is less educated or non-compliant based solely on stereotypes, they may under-explain treatment plans or fail to offer certain services, whether they realize it or not. One final thing I want to leave with you is this. Cultural competence is not a checklist. It's not something you learn in one training session. It's a practice, something you refine over years through self-reflection, meaningful conversations, and yes, making mistakes and learning from them. The more we listen, adapt, and reflect, the better clinicians we become. Not just for our patients from different cultures, but for everyone we treat. You now have 1 minute to answer the questions. And here are the answers to the questions. Don't forget to like, follow, and subscribe. Good luck.